Today, we are doing our first ever Zero Live conversations. And this is in response to all the questions that we get about hormones, menopause. And we just thought, you know what? In medicine, one of the fun things about being a physician is you get to be around other physicians when you're at work. And so you can actually do curbside consults and say, I have a question. What do you know about this? You're the expert. And so, I thought it would be fun if we have Zero Live members be able to have that curbside consult. And so that's what we're going to do today. So in the past, we got a lot of, interest in the mini medical school that we've been doing on Zero Live. And we thought we'll do the curbside consult. So that's what these Zero Live conversations are going to be about. So today is about menopause health and hormones. And a lot of people have questions. So here are 4 common hot topics in menopause right now that Dr. Scanlon is going to talk to us about. So hot flashes, bioidentical hormones, decreased libido, and healthy weight. So we will kind of be focusing on the physiology and really the curbside consults that we'd be asking her in the hallways at the hospital. So this is an opportunity. You'll be able to post questions, and it's really just going to be broad brushstrokes here. So we can't give any medical advice, and we'll talk about the disclaimer shortly, and also the fact that evidence constantly changes. So this is today, the snapshot in time, and we'll talk a little bit more about that in a sec. So I'm Naomi Parrella. I am the Chief Medical Officer at Zero and a physician. I work in obesity medicine at Rush University, and we are excited to have our featured guest, Dr. Susan Scanlon. And I have to read her bio because it's so impressive. So Dr. Susan Scanlon is a board-certified gynecologist, robotic surgeon, and president and chairman of the board of Midwest Center for Women's Healthcare. In addition, she's the medical director of Illinois for Unified Women's Healthcare, and she's the assistant professor at Chicago Medical School. She is a Menopause Society certified practitioner since 2010, formerly known as the NAM Certified Menopause Practitioner by the Menopause Society. She's also a certified Da Vinci robotic surgeon and a member of the Society of Laparoscopic and Robotic Surgeons. She's a graduate of Loyola Stritch School of Medicine and received her undergraduate degree from Boston College. She conducted her residency at the University of Southern California, Los Angeles County, and at Rush University Medical Center, where she served as chief administrative resident. Wow. She has received numerous honors, including Phi Beta Kappa, magna cum laude, and she's been named a top new doctor in integrated care by Chicago Magazine. Dr. Scanlon has been in private practice for over 25 years and provides gynecological and surgical care to women during all stages of life, from adolescence to postmenopause. And she's the author of a fabulous book called The Gyne's Guide for College Women. And she's given tons of talks and presentations, and she's been a featured speaker on podcasts and panels, leading wellness workshops at several national colleges. She's been featured in the media on TV, radio, publications, including Chicago Tribune, USA Today, ABC 7 News, Fox 32 News, WGN Radio, The Daily Herald, Lifeline, and even 17 Magazine. So we are going to step into this curbside consult with Dr. Scanlon. Thank you for joining us.
Well, thank you for having me. What an intro. I did not write that. My office wrote that up. So that's nice. So thank you for having me. I'm thrilled to be here. And what a great organization you have here with Zero. I think it helps a lot of patients. And so I'm ready to talk menopause. Whatever everyone wants to learn, I think we can get into it.
All right, plan for today, curbside consult with Dr. Scanlon, women's health and hormones. We'll have a Q&A section for live Q&A. And then a little bit different than our previous, we're actually going to ask for tips and tricks from the current audience so that you can share live, and we'll read them out. Rather than reading what people have submitted earlier, we're going to actually draw from live participants. All right.
That's fun.
So, Dr. Scanlon, the number one question that starts happening around perimenopause is, why do I not feel good? Let's talk about that.
I think that's a great way of starting. And in fact, most of the patients, when they come in the perimenopause timeframe, used to feel like they were in control of their life. They were managing their home, their job, their family. able to juggle and multitask. And then all of a sudden they just feel a loss of control over those things. And it brings them in. They say, this is how I used to be. And now, I can't sleep at night. I'm hot and sweaty. I'm tearful at work. I get embarrassed. I really care about my partner, but I'm getting mad at that person all the time. I used to like to have sex and now I don't have that interest anymore. And something's wrong with me. And so, and a lot of them, they're gaining weight and they're like, I haven't changed anything. And I'm still gaining weight. I'm very frustrated. So they haven't been to the doctor maybe for a while, maybe through a regular checkup, but, they had their babies and then they were managing them fine. And now they don't feel good. So they come into the office and that's usually when the perimenopausal timeframe is beginning. And that's on average between around 45, 46. Some women, it starts in their early 40s, but oftentimes it's in that mid 40s range. And that's when the hormones are changing, their body's changing, their hormones are not responding as the way they used to the signals that were coming from the brain, down to the ovary to signal to the uterus about their periods. So their periods start to become irregular. They don't create the adequate ovulation that's needed to create the progesterone. So they'll become estrogen dominant. That can lead to a lot of the symptoms of perimenopause, such as irregular periods. Their estrogen can decline sometimes and they get hot flashes. They can have surges of estrogen and get breast tenderness and headaches and everything in between. So it's changing because that's a normal process in life. Menopause is a natural transition. But their experience during this natural transition is so varied amongst every patient. Most women feel those changes lead to a lack of sense of control that brings them into the office. They're looking for some answers about how to feel better. So that's really what's happening, and it's universal. So if that's what you're feeling, I would encourage you to go see your doctor and talk through the perimenopausal transition.
Yeah, I think that's really important. This why do I not feel good is such a broad statement. And you're right. People have so many different ways that they experience this, right? Not everybody has extremes and then some people really do. So it's hard to know how to respond. When there's so many varieties of ways people experience perimenopause. What's the age that you said mid 40s?
The average age of starting perimenopause for the average patient is 45 to 46. Perimenopause is a transition. So it's typically over 5 years and completes at 51 for the average patient. But there are patients that present with their symptoms in the early 40s. Some patients will go through menopause at a faster pace, 3 years as opposed to 5 years. The hard thing is that, as you said, it's different for everybody. So they'll be with their book club, you know what I mean? Or they're in the grocery store talking to their friends and they'll comment that this is their experience. And someone's like, well, I don't have that. Am I supposed to have that? When is that going to happen? Or I had that 2 years ago, but I don't have that anymore. So it's really the uncertainty that I think is unnerving for a lot of the patients, where they just want to know, am I fine or am I not fine? So I think talking through what to expect or their specific symptoms and kind of what to expect coming up and ways that they can help them make them feel better is great. Some patients need significant management and other patients just need reassurance that, okay, you're on track in your perimenopause. And if these symptoms are tolerable, okay, let's keep in touch and we can always address it if things change. So it's very varied by patient. So if patients here tonight feel that way, like, why am I not just like my mom or my sister, my neighbor? It's because everybody's experience is individual, as an individual person. So that's common and is okay. So
Love that. Love that. All right, let's see if we can get, oops. Okay, here we go. All right. So the second question is really commonly, like you said, people come in, they say, I don't feel good. And then the next question is, so what's happening? And let's get to sort of the hormone states and maybe
yeah.
talk about what's going on there at a little bit more granular level.
Yes. So in the premenopausal, just so I think the definitions really are confusing to a lot of people. You read magazines or you see it online or whatever you're reading in the doctor's office, or it may be confusing. So I think there's premenopause, there's perimenopause, There's menopause, the point in time, and then you're postmenopausal. So premenopause is when that neurologic pathway between the brain, the ovary, and the uterus is in sync. It's working. You're ovulating. So at the end of the period, you're at the low of the hormones. And then as you move through the first phase, the follicular phase, you have the rise of the estrogen. When the estrogen gets to a certain level, along the way, you're recruiting an egg. At that level, you'll have this LH surge. That LH surge is telling that ovary, okay, release your egg, ovulate. If it listens and releases the egg, then your body, the ovary will then make progesterone. The progesterone rises, progestation. The purpose is to support a pregnancy. Remember, periods are to support a pregnancy. The uterus is the house for a pregnancy. Well, it's doing that job. The ovaries are now creating the progesterone. That lining on the inside's thickening up, stabilizing to welcome a pregnancy in there. Well, if your body says, nope, not pregnant, then that progesterone is going to decline. The drop of the progesterone is what stimulates the period, and you get the period. And so then you're back to that beginning of that phase at the low level of the hormones. So that's a premenopausal state where that cycle is occurring. And if it occurs and you ovulate and make the progesterone have the decline, you'll have a normal period. And a lot of women will feel pretty balanced. Everybody's a little bit different. We could talk about PMS sometime. There's a lot of people who don't have that normal process, like polycystic ovarian syndrome. They struggle with that, and they struggle with their weight. But if you're having that, that's the normal cycle. Then you come into your 40s and the hormones start changing. I always say the decade of the 40s is characterized by abnormal bleeding. It's really a struggle for a lot of patients in their 40s while those hormones are starting to change. That ovary is not going to be as receptive to the information from the brain coming to it, telling it how to function. So it's just not doing its job as well. And so they will not have consistent ovulation. So if you don't ovulate consistently, you don't make the progesterone. If you don't make the progesterone, you can't have the fall, which leads to the period. But furthermore, you remain estrogen dominant then. And so you'll get the side effects associated, as I mentioned earlier, a lot of surging in estrogen. You might get the breast tenderness or the headaches, and then all of a sudden you do ovulate and the hormones then decline and you're at the low of the hormones and you can get some hot flashes. And then, that imbalance, that up and down can lead to the mood swings. So there's a lot of side effects due to the hormones changing. That's a natural phase. Menopause is a natural phase. That transition's expected. 100% of people born as a female will go through menopause. They just will. It's just, how is their experience as they go along? So that's really what's happening. And it's interesting what things can affect that. So a healthy lifestyle will affect that. Obesity affects that. And so here for this site and for the patients who are interested here, trying to understand, if you look on the Menopause Society's website, which is a great resource. As Dr. Parrella mentioned, I've been a certified menopause practitioner since 2010 and go to the conferences. They're amazing. They release information on their websites that doctors can see, patients can see. And so something recently, I think it was in February, was how obesity, those patients have much worse hot flashes, and then they respond less well to hormone therapy approaches. So, a healthy lifestyle and getting to a healthier weight. There's no perfect weight for anybody. I think it's women, we're all sensitive. I gained 50 pounds when I went to college. Who gains 50? Nobody. I did. Oh, you did too.
Yeah,
Holy smokes. I mean,
that's
geez.
why I had to get into lifestyle.
Yes. I had to learn how to eat. It was like so traumatic and so
Totally.
whatever, it's life, right? It's life, right? You have to face that and learn strategies and struggles, and you make your way. So, but I think getting to a healthier life, there's no perfect weight, but there's a healthy range, and your doctor can help you get there. So I think it's really important to understand the importance of that lifestyle and how you'll feel better in your transition as you go through that perimenopause. But I see in the chat, just to clarify, to finish that perimenopause is that transition. So now it's not working. That's usually for about 5 years. It typically begins at 46. If you need a number, it's usually at 46. But everybody's different. That can vary. But 46 is your average, and it's about 5 years duration. It's completing at 51 for most women. So you're perimenopausal in a transition. The hormones are changing. That's when you don't feel great, typically, and brings you in. 51 is the average age of menopause. Well, menopause is a point in time. It's the definition of menopause is 1 year without a period. So it's normal that in that perimenopausal transition, you're going to start skipping periods. That's normal. It's expected. It's needed to get to the point of menopause, which is a year without a period. So when you get to that point, then you can say, oh, okay, a year ago that I was menopausal because I'm now a full year without a period. You need to always remember that date, because if you get it bleeding after that point in time, that can be a sign of cancer. So you always want to know, when was your last menstrual period? But that point in time is your menopause. And then after that, you're in the postmenopausal time frame. So those definitions, I think, are really confusing. But and once you're in that postmenopausal time frame, that hormone pathway is no longer working. You are not ovulating. You can no longer get pregnant. So a lot of people, there's also a struggle, as a worry is, oh my gosh, am I going to get pregnant in this perimenopausal transition? Which you can get pregnant. It's much less likely because the fecundity rate, declines. That's our fancy word for, probability of getting pregnant declines every year as we get older, but it's not zero. And you have to be a full year without a period confirmed to be postmenopausal or to be hit menopause. And now you don't need the contraception really anymore. So that's really, I hope that was helpful. And I hope that it helps clear things up for those definitions and what's happening.
Yeah, I think the definitions are tricky, and
Mhm.
that's super, super helpful. I'm going to go through some of these questions before we move forward because they're relevant to this part of our conversation. So, to kind of keep the flow, we have here, is it common to hit menopause at 45 or 46? And there seems to be some about age ranges. Um,
So that's perimenopause, the average age of peri, meaning when your ovaries are really not functioning properly. That pathway between the brain and the ovary, not only when the signals come down to the ovary, it's not receiving the information well. Um, there was, it's just an irregular release of the hormone. So it's multifactorial. It's also the receptors are declining. The ovary itself is aging. So not only it's not producing the hormone as well, the receptor isn't recognizing the information as well. And so it's just a decline in the function of the ovary, just like the rest of our bodies, decline in the function of a lot of things. So but it's 46. 46 is your average age of beginning that.
and when do you worry it might be too early? So, if somebody had the 12 months without a period at age 45, for example, is that a concern?
Yes. So the definition of there's early menopause and there's premature, and premature is under 40 and early is between 40 and 45. At this most recent Menopause Society conference, and someone said, what is that website? It's the Menopause Society. If you Googled Menopause Society, it's actually menopause.org is the website for whoever someone was asking. That's where your resources are. They talked about that this year. Instead of calling it premature menopause, they talked about calling it premature ovarian insufficiency when they're that young, because there has been research showing that, oh my gosh, oops, I got pregnant. Here I thought I was premature menopause, done, no contraception needed. When in fact, they may have a spontaneous ovulation. They may have some eggs that are left over that just, we're just sitting there. We see that all the time. Some patients, for example, come in postmenopausal bleeding, and on your list as a doctor, you're thinking, I wonder if she had an egg or two left over and she spontaneously released it. And therefore their body, they'll say, I felt like it was a period. And lo and behold, you do the ultrasound and it sure looks like they had released an egg. So that's not uncommon. So that's why they went to this ovarian insufficiency term rather than calling it a premature menopause. But those are very important things to talk to your doctor about if you had a premature ovarian insufficiency. So those 40-year-olds, certainly by 40, anybody under 40 up to 45, it's a conversation about hormone therapy, because you want to replace those hormones if you have a premature ovarian insufficiency, because they're really at risk for bone loss, because it's so young that they are losing their hormones. And so the teaching, and that's changed since, years ago, 10 years ago, we didn't, that was at the time when we were very stingy with the hormones based on that Women's Health Initiative study that came out that kind of got hashed and rehashed over for 15 years about really the significance of that data. But at that time, we took everyone off hormones, and really the women who had that premature ovarian insufficiency, it was not a push at that time to give them hormones, and they're now menopausal, really facing bigger problems with osteoporosis. So now we've learned from that, right? Science evolves, thankfully. Science continues to evolve, and the Menopause Society is amazing with their research. So I encourage patients to really look at that, what they put up for their patients. And they talk about encouraging hormone therapy for that patient population. So,
Wow. Yeah. So that's actually going to be part of our next question, I think. Let's see here. All right. So, what can I do? This is the stuff I think most people are interested in.
sure. Yeah,
So, what are the solutions? What can we do? And we had talked about, hormones and so on. So maybe we can dive a little deep into this area and help people understand. And also, related to weight, brain fog, fatigue, these are so common. And, and maybe some thoughts without necessarily having an intervention, things that people can do on their own as well.
sure. Okay. I think it's very important. I mean, I think, and you please speak to this as well. The foundation is always a healthy lifestyle. I mean, that's, we can do as physicians so many things to help you based on science. But if you don't have a healthy lifestyle, it's much more difficult to get those treatment options to help you, at least to optimize them, the benefit that you may feel. Certainly, lifestyle changes aren't the answer for everyone, for everything, but it certainly is a great first start. So I think, certainly getting to a healthy weight range is very important. To work with your doctor, work with a dietitian, work with Dr. Parrella. You want to work with experts who can help you get to a healthy weight. And that's a big conversation, but that's important. Eating healthy. What happens with women go into this, a lot of patients will say, well, Dr. Scanlon, I work out all the time. I work out constantly, and I haven't changed anything how I'm eating, and I'm gaining weight. Well, the problem is that's the problem. You have to actually change something. And I learned that myself. I was, 95% carb gal. I mean, it's just really, for a menopausal patient, that's just not a healthy way of eating. You really need a balance with protein and veggies in your diet. And because women become insulin resistant, and that they've talked about it in the research a lot, and you're just not, in a very basic way of explaining, you won't process the sugar and carbs like you used to. And that leads to weight gain. And that's very frustrating for patients. I'm sure you see that in your office as well. And the conversation about insulin resistance, I think, is really important to have with the patients, and meet with a dietitian to really learn what type of foods and drinks, sometimes it's the fruit juices, like what they're consuming is making it worse for you. So really a focus on protein and veggies is a foundation. I don't know how you feel about that, Dr. Parrella. Is that kind of your perspective as well?
Yeah, no, I'm totally in agreement. So, we've talked on these live events previously about insulin resistance and the fact that when insulin is very high, it stops fat burning, completely shuts it off, and then the body gets into a storage mode. And that's exactly what we don't want when we're in the perimenopausal state and postmenopause. I think because we naturally become insulin resistant over time, it gets worse. And so we have to be really mindful about it. And
Yes.
that's where the, interest, I got into intermittent fasting specifically because of this challenge. I was like, oh my gosh, I need some tools that are not tricky. I'm not able to monitor all my carbs and all my little details, but I have to run around and, do my life. So, but exactly, I think the protein and the veggies are important. And even if earlier we could get away sort of eating, and I also love my carbs, right? So, so I had the same issue, and boy, it's like, wake up call, right?
It is a wake
Seeing
up
how
call.
that, and,
Yeah.
and the symptoms of fluctuating blood sugars as we become insulin resistant also aggravate and get confused with perimenopausal symptoms as well. So, it all feeds into itself. So I found that makes a huge difference in my patient population as well.
I think so.
Yeah.
And I think a real focus on that. And I think it's hard for people to grasp that. I think they can take a medicine and it'll make them feel better when, again, the foundation of their lifestyle is so important. They'll feel better. You're less bloated, you have less brain fog. A lot of times the patients who have a lot of carbs, they have the biggest complaints of the brain fog. If they can reduce the sugar and the carbs, a lot of times that eliminates or significantly reduces that symptom. But they get that with that insulin resistance. If you're all wondering why is everything going right in the middle, that classic distribution of fat, in that perimenopause. It's naturally doing that anyway, but with the insulin resistance, that's really what's feeding that. So we talk about that in the office, and I refer them to people such as yourself and dietitians and something to try and help guide them along their way. And here, this Zero app sure seems like a great resource. Looks like all these patients are fully interested in that help. So, but that's a big. Here I'm like going back to the question, what we're focusing on. We went in this direction, but that's an issue that faces a lot of people. What else were we? Are we talking about just symptoms and what they can? Should we move into a
What are
topic?
yeah, so what are the things we can do,
Yeah,
for this time? And so what we can do is we can start answering some of these questions. But
perfect.
some
Okay.
of the most common complaints, for example, sex drive,
Oh, yes.
right?
That's
That's
a
an
big
area,
one.
hormone driven.
It's completely hormone driven and it's very common. It's one of the biggest complaints in the office is a reduced libido. And one of the second biggest is painful intercourse. Well, they kind of go hand in hand. If it hurts, you don't really want to have sex. So a key to it is to try and make it feel better in the vagina. So there's definitely some tricks that you can do and you can talk to your doctor about. And there's a lot of options too. And first, so making the vagina feel better. So as the estrogen declines, the vagina gets drier and it gets less stretchy. Just again, I'm using very basic language, but that's the easiest way to understand. So what you want to do when you first start out. So as a proactive measure, if you all put moisturizer on your face and taking care of your skin here, you really do need to take care of your skin in that department too. So using a vaginal moisturizer regularly when you're in your early 40s, definitely leading up into that perimenopause, I think is a good strategy. And there's a lot of different vaginal moisturizers that are over the counter. One that's easy and accessible, Replens. Maybe I'm not supposed to plug for any certain things, but there's Replens as a vaginal moisturizer that's very helpful for a lot of patients twice a week in the vagina. Or there's a brand called Reverie, which is a hyaluronic acid. It's hard to say that word, hyaluronic acid. That commercial where your skin's, they push it on. I don't think mine did it. It didn't come back. But anyway, the hyaluronic acid is what also helpful for the vagina. And so that's Reverie. So that's over the both are over the counter. One is that you would order online. That second product seems to help a lot of patients. So I would encourage you to start with a vaginal moisturizer to get started in your in your 40s, so that going into the perimenopause, it's moisturized, it can stretch easily. For the skin on the outside, a lot of people, they'll start to get pain at the introitus where, with insertion. And it almost forms like a ridge over time right at the entrance. So you want to, again, being proactive, you want to be a proactive person. Using moisture on the outside, one that's well tolerated is Aquaphor Healing Ointment. You can put that right at the opening and then up on the labia minora, not on the outer labia where the hair is, but on the inner one. Seems to really help a lot. If you're into more natural, then Unpetroleum is at the Whole Foods. You can always go there for a natural moisturizing product for the skin on the outside. So that's basic skincare. But as you go along further into, you enter further into the perimenopause and certainly postmenopause, it really is uncomfortable for a lot of patients. And so that's where using medical management seems to be helpful. For example, a vaginal estrogen cream, vaginal estrogen ring, or vaginal estrogen tablets are great. And those do not increase the risk of breast cancer. They do not increase the recurrence of breast cancer. Now, the package inserts say breast cancer. My son's an attorney. The attorneys in the world all make sure that all those things are in those package inserts, But North American Menopause Society tried to appeal to, the FDA to remove that information, but they didn't agree to do that. So it's important that the doctors talk to the patients about it. Some patients are really uncomfortable with it because they're worried. But if you go to the Menopause Society and read about it, the literature does not support it causing a breast cancer because it's a local vaginal medical treatment. So talk to your doctor about that, whether you're a good candidate for that. If that doesn't work, then there's a vaginal DHEA. Interosa is the brand name that's out there. Very helpful for patients. That's a bullet-shaped insert. It's every night. So it's a little bit more involved than it's regular. It's every night. If you skip a few nights here or there, it's still going to work. But for some women, they like that because it's an androgen. So a male hormone, which is in all our bodies, it helps with their libido. So that's great. That was an aftermarket finding. If that doesn't work and you want something by mouth, there's Osphena, which is an oral tablet, or there's a vaginal laser. So all those things can help make it feel better. But with your weight, if you feel uncomfortable in yourself, sometimes that affects your sexuality. You don't feel good. So getting to a healthier weight range may make you feel. It's very individual. It's your body, however you feel, no judgment. But sometimes patients will report as they got to a healthier weight range, they felt a little bit more sexual because they felt more comfortable with their body for whatever reason personal to them. And so that's to help it make it feel good. And then with regards to libido, there are some things you can do in the perimenopause timeframe. There's an oral tablet called Addii that's been approved for premenopausal women that seems to help some people. There is bupropion, which is basically Wellbutrin. I've never really found that to be all that helpful for the patients, but if you read it on the Menopause Society, they list it as something that can help you. There's topical testosterone cream that you could talk to your doctor about. If you read about Menopause Society, they are not fans of compounding hormones. It's mixed by an individual person in a back room. There's no regulation. Is it in a sterile environment? Is it the actual amount it's supposed to have? So I stick with bioidentical hormones that are FDA approved. That's what Menopause Society supports. It's what Mayo Clinic supports. What the American College of OB/GYN supports. So there are clinics all over that you can go to that they make a lot of money on this business of menopause. But really, you're our patients. So our goal is to take great care of you with things where science supports it. So I would encourage you to stick with what the Menopause Society supports and go with bioidentical hormones, which are great. They're natural. I've been prescribing them my entire career. They're not new. They've been out forever, but there are forms of them that are FDA approved: patches, creams, mists, oral. But they're bioidentical natural products that are FDA regulated. So that's from a safety standpoint thought to be the way to go, as opposed to the custom compounding. So I'd have caution with that, and I would not do pellets. The only time I've seen male pattern baldness in my career is with someone who's been on pellets. You cannot get them out. They are in. You have to wait for them to go away. And when you're losing your hair in a male pattern fashion, that's the last thing you want to do is wait for that thing to completely, dissolve in your body. So I would stick with talk to your doctor about the most appropriate medications that you can use. So those, I think, are some reasonable. Someone here, I now have clitoral atrophy and I used to have a healthy sex life. Yes. So that's, again, you can apply some estrogen cream to that area in order to increase, that moisture in that area as well. It doesn't absorb as well as it does in the vagina. But with that clitoral atrophy, you could get started with that. Talk to your doctor about it. And there is also, off-label some Viagra products that you can use. They discuss that at the Menopause Society conference, but it is off-label. That helps with arousal. So you could talk to your doctor about that too. The Reverie suppositories are expensive but work well. There are coupon codes. You could ask your doctor for a coupon code to get that cost down. Are you able to use Interosa and a libido product? So yes, you could use, if you're premenopausal, you can use Addii for libido, and then you can use Interosa for painful intercourse and vaginal dryness. Yes. Um, does it help with vaginal prolapse too? Um, no. Vaginal prolapse, that just means fancy word for everything's kind of falling down. What isn't falling down, right? Everything starts sagging, sadly, but the vagina does too, especially highest rates are in Caucasian women, women who have had multiple babies. Really only takes one baby, to come through there. You have some injury there. It's an injury. You love them, but they harm your pelvis. And so really doing Kegel exercises is the first start. Second is that you can work with a pelvic physical therapist. We have vaginal weights in our office. Believe it or not, there's little mini weights that you can put in there. I would talk to your doctor about a medical grade one. There's stuff on the internet I've seen that are kind of scary. I don't know what shapes they've got these things going on with, but the ones that look like, the old fashioned OB tampons. I don't know how many of you, where it's just as the string, there's no applicator. That's a great shape for it. And then they unscrew and you can put the weight inside, and there's typically 5 different weights. So you insert those, do your Kegels with that. It helps you build your pelvic floor. Again, pelvic physical therapy. There's pessaries that you can do to hoist things up, and then certainly surgery. So you'd want to talk to your gynecologist about the significance of your prolapse. But the estrogen cream's not going to get rid of that. Once you have that, it takes more physical therapy, exercising to improve that.
I'll work my way up on some of these questions. We got a little earlier. Let's see here. I'm having trouble sleeping the whole night. I'm averaging 4 to 5 hours, and that's not enough for me.
Right.
Any thoughts on the sleep issues and what to do about that?
Yes, the sleep, most people need 7 to 8 hours in this stage of life, but it's tough. It's tough on most patients. So as you go through that perimenopause and into the menopause, that's a significant impact on most patients. Not necessarily forever. Most women will outgrow that. Just so you know, most people get over this hump and they feel good. They just need to get there, So most people experience symptoms during that 5 years and a few years afterwards. Oftentimes 3 years following the last period. So just so you know, that's kind of the range of what people experience. Everybody's a little bit different, but the sleep is a problem. And so certainly natural approaches like mindfulness, meditation before you go to bed, yoga, just with the restorative type of yoga. Don't be doing the big aggressive, what is that? I don't know my types of poses I should, but the
The
tree
hot
and,
yoga and stuff. Yeah.
your heart
Yeah.
rate may be going up trying to maintain that pose, may not be your best thing, but a restorative approach, those behavioral techniques, really the mindfulness and bringing your breathing, those breathing techniques, believe it or not, really do help with that. A key is in the middle of the night, do not take your phone out when you wake up, because that light in there is problematic. Just another behavioral trick, a lot of women in the transition or even afterwards, they get more anxiety. Anxiety is really common, and you get tension. So they get tense. They're mad at people they're not usually mad at. So if you're like, gosh, the patients are like, I love my husband, but I'm yelling at him all the time. And then I'm like, why am I yelling? Or I'm yelling at the kids or the lady in the jewel line, like, what am I getting so mad for? Common, super common. It's super common. And then anxiety. So in the middle of the night, they wake up, then they're like, I'm awake. And then they start thinking of all the things they have to do tomorrow. And then they don't want to forget it. So what do? They do this circling. And so a strategy that I learned along the way of my journey is women need to transfer their anxiety somewhere else. They do well if you can put it somewhere else so you remember because you don't want to forget it. So you transfer that to a piece of paper, the old fashioned, don't take notes in the phone, the old fashioned paper and pencil. You don't turn the light on. Try and squint your eyes as you're writing. Don't be like, just try and squint them. You don't even have to read it tomorrow. You just want to be able to write it down so that you don't forget. and you write, okay, I got to take the dog to the vet. I have to pay the taxes. The fridge is broken. My kid, I got to call that Italian teacher about like kids flunking grade, whatever it is. You're transferring that over to the piece of paper. So in the morning, and then you say to yourself, I've got it. I'm not going to forget it. That's a really important tool in the middle of the night. And then furthermore is a personal worry session. Again, a tool I learned along the way. Again, people with this anxiety, also they have a hard time multitasking as they enter this phase. And that's so frustrating. It's that I don't have an answer for, and it seems to be something you have to learn a new technique for. So keeping a written list with you or in your phone, whatever your list may be. And so scheduling a personal worry session, I don't know for men, but for women, do well with that. You have to teach yourself to do it. I do it every day at 6 a.m. to 6:30 every day. And it's like, oh my gosh, I've got to do all these things. Sometimes I pull out the list that I made from the night before, try to decipher what I wrote, but you're worrying, you're all in, like cry if you have to, get mad, whatever. And then at 6:30, you're done with that. So I'm done with that for today. I have to go to work. I've got to take care of my patients. I've got to prepare for a webinar, whatever I'm doing. Right. And then in the middle of the day, when you're like, you start circling. That happens, especially perimenopause and early menopause. You say, nope, I will deal with that anxiety tomorrow at 6 to 6:30. I've got to keep going today. Let me take my list out and tackle the next thing. So those are two strategies that I did personally incorporate in my life when I went through this whole phase, and still use those to this day. So I pass those on to you and hope that helps. For some people, they do all these behavioral changes and it just doesn't do the job and they need some medication to help them. I personally do not prescribe sleeping pills. I never have. However, some hormone therapy does help with sleep. Science has shown that to be the case. The one that's best for it is the progesterone, the bioidentical progesterone, the prometrium. One of the biggest side effects is sleep. So taking that at night before bed, really from a medication standpoint, seems to help a lot of people. And from a supplement standpoint, melatonin, there's some literature. You could look at Mayo Clinic's information on that. You could go to their website to look at that. And magnesium, magnesium helps a lot of people, 200 to 400 milligrams. It helps not only with some sleep, you can do it at night, but it also helps with leg cramps, constipation, and headaches. So talk to your doctor about what options you have. I would really discourage you from sleeping pills. I just think they're addictive. And if you can find a healthier strategy, I would do that. But there is science behind hormone therapy to help you with that. And so talking to your doctor about that would be an option.
I love that you linked anxiety and sleep, because a lot of times I see in my practice, of course, I'm seeing people come in who are concerned about their weight.
Mm-hmm.
And so they're anxious. They might have a glass of wine that interferes with sleep.
Mm-hmm.
They may wake up in the middle of the night or not be able to sleep. They get up and they go and have a snack. And so now they're interfering with the body's circadian rhythms and cycles. And so this is where, again, I come back to the fasting and really honoring the cycles. And so one of the things that some of my patients will do is we'll say, okay, you're going to fast from any sugars or alcohol for however many hours that they've determined, and they can use the app for that. They might decide that they're going to use the app to help them figure that out and kind of track what happens with their sleep, because we can track both. And I think there's different ways that we can sort of start understanding these hormonal changes affect anxiety, affect sleep, then affects behaviors. And then we might be too tired to exercise in the morning and all of these things. So I love that. And your tip about transferring that anxiety onto paper. So I teach my patients about the brain dump. And that's what we call that, is really putting everything on paper. And then, of course, that really does help be able to unload. And it seems to work for men and women. So it does not seem to be a menopause phenomenon.
That's good to know. I learned something tonight. Okay.
So that's good. Good. All right. So we'll answer maybe one more question. Let's see. Is there a way to know where you are in menopause if you've had an ablation? Maybe we can explain what an ablation is real quick, and then Mhm.
So that's a great question. So endometrial ablation is a great tool, technique that a doctor can do, a procedure to stop abnormal bleeding. So it's used for patients that really struggle with their periods. Maybe they tried birth control pills or IUDs or had a DNC and it just didn't work. It's hormonal bleeding. It's just not getting better. And an endometrial ablation is a technique. It's minimally invasive. There's no incisions. The doctor will put a little TV camera inside the uterine cavity and visualize the space, and then it sounds gross, but they burn that lining, so it's called an ablation. And a substantial number of patients have significant reduction in their flow. Some don't have any period at all anymore, so it's a great technique. However, in the patient who asked the question, she had the benefit of not having a period anymore, so probably was thrilled about that. But it does make it a little bit more challenging to know is the person in menopause, because going back to what we said earlier, the definition of menopause is a full year without a period. Well, if you don't have them, how are you supposed to know? It's the same with the IUDs, the hormonal IUDs that are used for both contraception as well as controlling their periods. Sometimes they just don't get a period anymore after that, and it's confusing. So we would do a hormone, we would check their FSH and estradiol, their follicle stimulating hormone, FSH, that's the brain hormone, and their estradiol, which is their ovarian hormone, to see is it consistent with menopause levels. We would do it at age 51. Why 51? Because that's the average age that a person completes menopause. So that's really the only time that we would use the hormones for sure, hormone levels. Again, going back to there's clinics all over the country that are popping up and doing all the pellets and a lot of hormone blood tests and making decisions about how to help you feel better by just reading a lab report. That's really not, when you go to medical school, that one of the first things they teach you in your first year, when you're like the low man on the totem pole drawing the blood and you have to pull up the labs, what do they tell you? You treat the patient, you don't treat a lab value. Well, that definitely applies to menopause. If your doctor takes care of menopause for a living, they will listen to you, they will hear what you have to say, and they will work with you on strategies to help you feel better. And you don't need a lab. You are perimenopausal or you are done and you're menopausal. So I would discourage, as Menopause Society, as Mayo Clinic, as ACOG discourages you from managing your menopause with hormone levels. It's expensive. It hurts your arm. It's really not needed. So the only time, there are a few situations, and one of them is what this patient asked about, is the ablation, because you just don't have periods anymore. So you really kind of want to know, am I done? And why is that? Because even ablation patients still need contraception. Remember, you're not you're not free of that risk of pregnancy until you know you're done. So that's how we figured out.
Great. All right. Let's see. One more. This is really about joints. So is it common for some to experience frozen shoulder, or I'm going to say joint problems in perimenopause
Yes, as the
due to the
estrogen
hormones?
decline, yes, when the estrogen declines in your joint spaces, there is definitely more joint pain. So you can start off with glucosamine chondroitin is used all the time for joint pain. You could start with that. Exercise, physical therapy, all those things can help you. Some people end up needing to do surgery down the road. It is not related to osteoarthritis, though. So that's something different. So you don't want to mix that. You can't blame the decrease in the hormones on the osteoarthritis necessarily, but you can on the joint pain. So some patients really improve that with hormone therapy. So that's on the list of potential things that one of the symptoms that you have, it's not an indicate, if that's your only symptom, that's typically not the indication that we would start you on hormone therapy. We'd look for other things first. But a lot of women where they have a multitude of hormone symptoms, menopausal or perimenopausal symptoms, one of them is joint pain, they start on hormone therapy, and a lot of them do feel better.
That's so awesome.
Yeah.
All right. So we have answered Dr. Scanlon, you have like done such a great job of firing through these questions and being grilled to death on this. So thank you for your curbside consult
Sure.
here. What I would like to do is then just in this comment section, if we can have some Zero members who are with us today, share some tips and tricks that you might have had along the way. And we will read some of these off, or I guess we can all kind of read them, but let's see what people have found that's helped them through this time period. I think, Dr. Scanlon, you had shared writing down, basically transferring the
Transferring.
thoughts. And
Yes. I'm glad to hear that that paper, you do the same thing for your
oh
patients.
my gosh,
Yeah.
absolutely, absolutely.
Yeah.
And I find actually when I do presentations for organizations as well, this is very popular technique that many leaders say they use to help them sort of manage and deal with all the life stressors.
Oh,
So really
great.
useful tool, absolutely.
Great.
And then let's see. So somebody found Reverie helpful, while Repellence was not.
Great.
PT and gradually went away with stretching. Took almost
Yes.
2 years. Thank you so much.
That is a very good point, Ursula. Pelvic physical therapy is a great additive measure for that painful intercourse. So I'm glad that I'm glad you brought that forward. Yes, it's great for patients.
And for frozen shoulder too. Yeah, it could
Yeah,
go both ways. So connective
all body
tissues.
parts. Seems, but a lot of people don't
Right,
know there's
right.
pelvic physical therapy. There are specialists in just that. We have one in our office. I mean, that's how common,
Oh, that's so
that they're
great.
needed.
Wow.
Yeah. So
Yeah, yeah. So veggie protein smoothies, you get veggies, proteins, and hydration. All
mm,
right.
great.
Deanna Coleman has regular exercise has worked wonders for my stress levels. Good job. And
Yes. Great.
Rosa, just some old, I think that must have cut off. Walking helps me. Nature's meds. Yeah.
Mm.
Let's see.
Oh,
Fashioned
good.
earplugs for sleeping.
Oh,
That's
okay.
great.
Yeah, that's a good
All right.
idea.
Walking
Hmm.
gentle yoga works for me. Uh, frozen shoulder can also indicate undiscovered high blood sugar.
Hmm. I
Walking
didn't
and water aerobics for my painful joints. I'm sorry, what were you going to say?
I did not know that. Is that true? The frozen shoulder
So,
can
well,
indicate high blood sugar? That's
what can happen is high blood sugars can basically gum up the joints, right? So I kind of think about it as the
mm,
body's kind of like a pressure cooker. And so if you put sugar, protein, and water, or fluid and heat it up over time, it's going to become a very hard candy, right? It becomes a toffee. And that's what
wow.
happens in the body. So if we have very high sugars and they're circulating around, it sort of coats the joints and can create some pains and arthritis. And obviously,
Yeah.
what you don't use, it sort of gets crunchy.
Yeah.
So
Well, great tip
hot
then,
yoga. Yeah, right, right.
right?
So again, this goes in line with insulin resistance. So insulin
Right.
resistance means the sugars are consistently high and we are going to be creating inflammation in the body. It's a
Yes.
precursor for a lot of other chronic disease. So, all right. So, we've got some tips and tricks, and thank you for sharing those. We've got some upcoming Zero Live dates coming up on May 20th. We have Dr. Meeta Shah, who basically ran the COVID response at Rush University as an ER physician. She'll be talking about stress, success, and metabolic health. On Monday, June 10th, we have Dr. Jeremy Allen, who's going to talk about muscles and movements. He's a team physician for several of the professional sports teams here in the Chicagoland area. So, May is Mother's Day. So, we wanted to focus on women's health. And June, we're going to be focusing on Father's Day. So, we also wanted to invite you to join Zero Live Friends, tap into the power of zero. Learn from and share your best tips with the Zero community and inspire others by posting your progress. You can tag Start at Zero, at Zero Longevity, become a Zero Life regular, invite your friends to join the fun because it's way more fun when you have other people doing this as well. We've got a ton of resources. So we are the best fasting app. I mean, that's why, we do this and learn the science of fasting. You can also track things, you can share, you can follow us on social. definitely join in the fun. And we are so grateful for everyone joining today. And this will be on YouTube. So be sure to share it with other friends so that you can all talk about it and give us some feedback. We'll be very excited to learn your thoughts on this Zero Live conversation experience.
Yeah.
Dr. Scanlon, thank you so much for joining.
Yes, I had a great time. And if any of you patients need help, I do telehealth, and you can set up an appointment. I'd be happy to help you. I see so many of my patients on here. It's so exciting.
Awesome.
So thanks for having me. I thought this was, I mean, you do a great job. You're so well respected in Chicago area for the work that you do. I send you patients clearly, and thanks for
Goes both ways.
taking
Thank you so much.
taking it further. So thank you.
All right. Thank you, everybody.